use that as a transition to introduce Arnie and his team, who are going to give one view, one kind of a different approach to how we might make some progress on this. And as they're coming up here, I think on the panel, I'll introduce them. Arnie's been introduced, and he's going to be joined, I believe, by Dr. Amy Todd. She's a clinical assistant professor here at Stanford in their stroke center, and in the Clinical Effectiveness Research Center, she is a fellow. CERC, C-E-R-C, stands for Clinical Effectiveness Research Center. Dr. Jared Conley is a MD PhD candidate and a CERC fellow, and Lucy Kalanithi, Lucy, if I'm pronouncing that right, is also a CERC fellow. Arnie?
All right, someone other than me is going to get the slides up. It's funny, when I, in a room like this, I'm sort of struck by how many of you I've had a chance to work with in different capacities over the years. I'm going to start this talk by talking about a particular facet of my career, which was 6 years as a congressional advisor, giving me an opportunity to not only advise Congress on MedPAC, which is what I was supposed to be doing, but also beginning to understand American health politics, which have a direct bearing on the nature of what we're going to talk to you about for the next 45 minutes.
Could you speak up, Arnie?
Sure. Is that more audible?
Yes.
Okay. Great, okay. So, I don't know how many of you, actually, I think before I spent 6 years in Washington, I'm not sure I was really aware that the Congressional Budget Office every 6 months issues a federal budget forecast, and the central graph they show is the federal government's debt as a percentage of GDP. This turns out to be really important because if you're a debtor like the U.S. and over the last 50 years, the people who hold your debt have gone from being people who have a certain amount of, who actually have a fair amount of patriotism, because it used to be that only Americans held Uncle Sam's debt, to a world in which a non-trivial portion is held by people who simply are in it for the interest rates. They have no mercy for Uncle Sam or his country, and this gets a lot of people in Washington nervous, because if that ratio gets too far balanced, they might raise interest rates, which then would likely severely depress American economic growth and our ability to do almost anything, including pay for care for people who don't make a lot of money. So the most important thing for you to see about this graph is that if you look on the left side, that blip on the left side was World War II, where we sort of borrowed to the hilt, to pay for all that stuff pouring out of American factories. And then we worked it off. And then the second blip is the more recent one, was the economic meltdown, which we're spending a lot of money, but a lot less money was coming in, so things didn't. The ratio got a little bit, began to approach World War II levels. And then the two things to look at are those two curves you see going forward into the future. This is the CBO's budget projection, and again denominated in terms of debt as a percentage of GDP. GDP being our ability to pay the debt back. And people are very scared about this, and the thing that scares them the most about it is that roughly 70% of the projected increase is attributable to federal health care commitments. Medicare, subsidizing the near poor, Medicaid, etc. And so thus you see why here at Stanford we might dedicate a research center completely focused not on improving quality of care, but on lowering per capita spending in a way that does not slow down progress in quality or patient experience, but whose primary design parameter is lowering per capita spending growth in the United States. That's what you're going to hear this morning from a team of young research fellows, now many of them moving on into other facets of their career, including faculty here, who basically asked the question over the course of a year: if you methodically thought through what you need to do to not only reduce strokes and and disabling strokes once a stroke occurs. But how would you do it if your design objective was to simultaneously reduce per capita spending? A tough job, but one that society is increasingly hoping that all of us collectively are going to do. So I thought I'd just now give you a 5-minute introduction to how we do this. What's our manufacturing method for coming up with a new approach to delivering care for stroke prevention and stroke treatment that would actually lower per capita spending? And obviously the first thing we can do is as was being suggested by one of the prior speakers, is at least understand what's happening at the current price performance per frontier, or the price quality frontier. And this is thanks to IHA and all their wonderful work in the P4P program. This is kind of a distribution of all of our roughly 200 plus health insurance risk-bearing medical groups serving the commercial population, at least in this graph, and many of them serving the Medicare population and MA population as well, of the relationship between quality. The vertical axis is the quality of care meter. Okay, so the higher you are on that, the better the quality. And then the horizontal axis is the health insurance fuel burn meter. It's not how much you're paying to the medical group, it's how much the medical group is incurring of the health plan's money, including patient out-of-pocket obligation, per capita per year. And believe me, having chaired the committee that came up with these two measures, this is about as risk-adjusted as it can get, because the physicians who were being judged and whose income was going to be affected, they paid attention to these two measures. It took us a long time, but we finally got there. And as you can see, so idea one is simply figure out what's going on in what's called the value frontier, that sort of upper left, the far northwest quadrant, and copy it. And if you were to bore into that, and I've done some work on that, and we're now actually finishing up another study called American Idol in Medicine, again focused on this, understanding what in the world is going on at this frontier. Okay, I see what happened. Well, I was going to tell you what we find, but I'll do it by memory. Basically, you see a number of things. First of all, this idea of intensifying care for the highest risk subset of your population, what Steve referred to as the ambulatory intensive care unit. You see varying forms of that. And it's been going on forever, just not as successfully at first, which was in the telephonic case management was our first attempt to do it. Didn't work out too well, and so we've now seen these life forms, some in the forms of primary care medical homes, some in the forms of actually moving the patients over to intensified AICUs. Second thing you see is a more systematic attempt to understand and reduce variation in practice patterns among physicians and among hospitals if you have more than one hospital in your network. And a couple other things that are not the center of this discussion, so I'll move on. But you do see some of these things. But if you had the bad luck of being one of the research fellows we pull into our center next year, here's essentially what we'd be asking you to do in coming up with a new care model design. By the way, this is the design coming out of our stroke prevention and stroke care team. We pick different types of topics every year. This year, actually, the new incoming fellows are working on a much more affordable approach to high-quality surgery. So here's what goes on inside this design factory, and the fellows have roughly about 8 months to come up with an answer. And the first thing that you begin to realize is that there are two jobs you have to do to come up with a more cost-effective care model. Actually, not more cost-effective, a cost-saving care model. Very important distinction. For those of you who know anything about cost-effectiveness, these are care models that would have a negative cost-effectiveness ratio. That is, they would improve health and reduce per capita spending. So the first thing you begin to realize you have to come to terms with is you can't just prevent blindly. You have to come up with means of intercepting declines in health status in which the intervention you come up with costs less than the downstream savings that you're generating. And this turns out to be a non-trivial job. If you remember the CDC's analysis of the Healthcare 2000 or Healthcare 2010, they actually methodically said of all these things we recommend to prevent a health decline, whether it's the primary, secondary, or tertiary prevention, how many of them actually save money? And I think of the denominator of like 30 things, one thing saved money, smoking cessation counseling, and one was too close to call, which is flu shots. Everything else was nice, but it just aggravates the problem that Uncle Sam has. So challenge job one is you have to come up with a design that actually reduces cost, and again, near term. You can't come up with something that costs X now and saves you money Y now, but the Y is Y later, but Y is so far in the future that if you apply any kind of value of money, you're still spending more. And then secondly, whatever you do to take care of populations, you have to produce it more efficiently. The second thing we do is we sort of mix the old and the young. So we deliberately disproportionately end up with fellows who are between 25 and 35. And the idea here is let's pick people who's, unlike me, whose thinking is less grooved, who've got more ability to think laterally. They've been more in touch with things they learned as undergraduates and a more diverse set of exposures. But then let's mix them in with people who've tried and failed many times before and occasionally succeeded to get that blend. And what we end up with are composites that are formed from three primary sources. First, the global value frontier. The fellows, I help them network, and they find their own ways of networking all over the world to basically search for ways of delivering, in this case, preventing stroke and treating stroke that would cost less, actually reduce per capita spending, and improve health. That's the so-called global value frontier. And they've been to Canada, and they're Skyping with people in Finland and Australia and Hong Kong, etc. The second is they systematically mine emerging science and technology, because that's where, moving beyond today's value frontier, that's one of the places that you might search. And the last thing they do is they deliberately interview people who are currently delivering, in this case, stroke prevention, stroke care, and people who are receiving the services, and focus in on one question. What absolutely disgusts you about current care delivery? And the idea being, if you can come up with the most cost-effective solution in the world, but if it doesn't address the most deeply felt unmet needs of current clinicians and patients, your probability of getting it adopted are going to be low. So we focus in on so-called disguster analysis. And it doesn't take long to get people to talk about what they really don't like about healthcare, whether you're asking clinicians or patients. I'm going to just maybe close by saying, since I've had a chance now to observe 7 different design teams focused on very different facets of healthcare, I thought I'd just share with you kind of my impression as they begin to come up with these designs that actually are projected to substantially reduce per capita spending while simultaneously improving health and patient experience. There's certain common themes that emerge, and as these fellows tell you about the new model they came up with to reduce per capita spending for patients at risk of stroke or who are having strokes, you'll hear some of these themes resonate. The first is beginning to realize that if only 10% of health status is actually directly affectable by how we traditionally define medical care, then you've got to begin to expand your vision for what healthcare is to begin to leverage some of those other variables. And Bob Kaplan obviously referenced some of those, and many California health systems have really excelled in this. And then secondly, the culture in which your clinicians and operate, and then inevitably influences the patients. Historically, I'm not sure we've done all that well at conveying to our patients that the people on the team really care about how they're doing. I don't know how many patients actually, if you were to say to them, to what percentage of Californians, I wonder, believe that if they don't do really well on taking their pills or exercise a day, that it really profoundly matters personally to their doctor or the nurses they work with. I think it's not as high a percentage as we wish it would be. Culture of parsimony, it's something hard. It's hard for clinicians and patients to move into this culture. But if you go to places like Theta Care and Appleton, you begin to see how it's done very beautifully, and it's completely consistent with high quality of care. And lastly, this notion of culture of reliability. Once you decide what better is, how do you assure that it happens almost always? And then control. my intuition of, as you begin to look at these care models, not just that we're inventing, but others, you begin to see this interesting evolution in which physicians are beginning to, particularly expert clinicians, are getting moved up into something more like the control tower at SFO. And people actually doing the work, particularly, especially when you have, so I call it, it's clear as to what it is that needs to be done, and in the cases it is in stroke prevention, that actually do the work are people who are less expensive, and both of whom are supported by the third control layer, which is information technology that begins to make it much easier to monitor what's going on, to see red lights, green lights, and yellow lights, and to know what to do once those lights go off. So enough said about kind of the environment. I want to now invite up these young inventors who've been at it now and now have a new care model and now are working with health systems all over the country. And any of you who are interested as health systems in testing the new care model to actually assess whether or not it indeed reduces per capita spending, improves health, and reduces patient and clinician disgusters in the process. So come on up. And by the way, while they're coming up, I'll just tell you a little bit more about them. Lucy, her last name is pronounced Kalanithi. She's sort of a ringer on our team in that she's an internist who after 2 or 3 years of training on Phil Madvig's team at Permanente Medical Group, came to us. So we a little bit of an advantage in selecting Lucy for the team. Amy Tai is a stroke neurologist, and for any of you who's ever had clinicians who've had a patient, in a community hospital, and they've come in with a stroke, and you've called the Stanford Stroke Center to say, here's the situation, what do I do? Often Amy is the person you're talking to and have been talking to. And then Jared Conley, who sort of brings a wonderful set of disciplines to the team. He comes from Eugene Nelson's team at Dartmouth, in management science applied to improving healthcare value, and is also, he's sort of the future of what I think will be at the top layer of medicine. He's just wrapping up his training in getting both an MD and a PhD in management science. So come on up and let's hear what you've invented.
So through our research and design process under the mentorship of Dr. Milstein, we assembled key elements of a stroke care model that we believe can save healthcare costs, and it's summarized here in the acronym ACT, A-C-T. The first goal is to avoid vascular risk by economically maximizing preventive medication use. The second piece is for patients who do go on to have a mild neurologic symptom who are traditionally admitted to the hospital. And for those patients, we propose to widely convert hospital care of transient ischemic attack and mild stroke to care in safe alternative settings for most patients. Third, for those with more severe neurologic events, our recommended delivery improvements reduce disability by transforming stroke care with faster TPA treatment and improved transition to post-hospital care. Application of these elements can improve outcomes and the experience of care, and we estimate that when combined, they can reduce safely lower healthcare costs by 11% for stroke and related conditions. The next slide depicts in more detail the first set of recommendations, which I'll go through. And those center on preventing stroke and other vascular events. As you know, the science in this area is clear. The challenge in healthcare delivery leave a huge opportunity for improvement, and as Dr. Shortell and Dr. Wright have shared with us already, we've had both victories and challenges in this area, including the fact that though effective hypertension treatments have been around for 50 years, hypertension control rates across California tend to be under 70%. The proportion of American adults at moderate to high risk of a near-term vascular event is 20%, either defined by already having had a prior vascular event or an ominous combination of multiple risk factors. And despite great interest by physicians, fewer than 75% of these patients have received the correct protective prescriptions that we all know about, statins, antiplatelet, and antihypertensive agents. And under half take their medications regularly and precisely. We aim to proactively identify this at-risk population, making use of data from medical, billing, and pharmacy records. And in addition to those with a prior event, we want to include patients who've not had a stroke or other vascular event, but who have a high score on clinical risk calculators. We envision a vascular risk reduction strategy that's targeted and efficient and that improves both prescribing and adherence. And over the past year, we've had a wonderful chance to talk with and visit leaders in these arenas, and our recommendations are at the intersection of groundbreaking work by Kaiser Permanente, Tom Bodenheimer's Center for Excellence in Primary Care at UCSF, the Veterans Health System, Australia's COACH program, Right Care Initiative, and others. As we'll learn more about today, a recent JAMA article by Drs. Mark Jaffe, Alan Go, and their colleagues in Northern California Permanente Medical Group described Kaiser's success in doubling hypertension control rates through care delivery innovations. From 2001 to 2009, hypertension control in Kaiser patients went from 44 to 80% and above, while state control rates hovered around the 60s. One of their key success factors was an organized system of proactive population outreach and review using a hypertension registry. And we also got to learn from Drs. Ray Bogany and Jim Duddle in Southern California, who had similar success using evidence-based care protocols and including non-physician team members. We too envision an efficient clinical team that fills in care gaps. The structure we believe to be most efficient is a core of nurses, or as the Right Care Initiative also supports, clinical pharmacists, who identify high-risk patients and act on algorithmic protocols designed and approved by physicians, and who are joined by lower-cost health coaches who provide additional encouragement to patients. For patients who have not been prescribed the necessary medications, the core team can arrange for low-cost generics, reaching out by phone and doing remote monitoring to allow for convenience and ease at a lower cost. The VA and health partners have also led the way in this arena, achieving risk factor control in an additional 20% of their patients using this type of efficient care method. And Dr. Amy Tofigi and her team at USC are studying related methods to improve outcomes specifically in patients who have suffered a recent stroke. To boost adherence, we include well-trained medical assistant level health coaches, and inspired by Tom Bodenheimer's work and the COACH program in Australia, we believe this coaching can be done by phone as well. Along with motivational interviewing, coaches are trained to address all barriers to adherence, including non-medical reasons often missed by the healthcare system, like low health literacy and financial barriers, and we hope to bring an additional 5 to 10% of those at elevated risk into good control in this way and save overall costs. As a final insight for prevention, one of the top adherence barriers for patients is out-of-pocket cost. Aetna removed copays for cardioprotective medications after heart attack and achieved net cost savings on cardiovascular disease. Kaiser also had success waiving copays for blood pressure checks. Based on the medical literature and the work of other innovators, we believe these efficient, low-cost care methods can not only improve health, but reduce overall healthcare spending. I'll hand off now to Dr. Amy Tai, who will address cost-saving care for those patients who, despite aggressive prevention measures, go on to have a neurologic event.
Thanks, Lucy. So next, we're going to focus a little bit on people who present with transient neurologic symptoms. That's what TIA stands for. It's people that oftentimes have a short episode of mild symptoms, such as a weak hand, or loss of vision in one side of their visual field, but oftentimes present to the emergency room with a normal physical exam. The vast majority of these people traditionally present to the emergency room, where normally they stay in hospital for an average length of stay about 2 to 3 days, and they get a standard bevy of diagnostic tests, including imaging as well as blood tests, and subsequently get a normal kind of bundle of secondary prevention medications and subsequently discharged home. What we're recommending is that we triage them in the emergency room, and Dr. Albers from the Stanford Stroke Center will speak a little bit about the Stanford's personal experience with this protocol, where we would be evaluating the patients in the emergency room, subsequently imaging them, looking at the blood vessels in their neck to see whether they need short-term, near-term surgical interventions, or potentially could be safely evaluated in the outpatient setting within 48 hours. The people that are deemed medically safe to be discharged home would be offered using shared decision-making techniques such as the option grid that we learned from a mentor, Glenn Ewing. And subsequently, we estimate by speaking to innovators around the world that we predict about 50% of patients who would be offered this option would elect to go home and be evaluated as an outpatient, and potentially addressing some of the disgusters that Arnie alluded to, where a lot of patients really don't want to stay in a hospital when they feel physically quite well. The patients that are going to be going home, we would be starting their secondary prevention bundle while they're in emergency room, and then subsequently having guaranteed outpatient follow-up within 48 hours. We think that the most cost-efficient way of doing this would be using an advanced practice provider such as an NP or PA supervised by a stroke-trained neurologist to maximize the protocol type of care that these patients would be getting. Next, we're going to talk a little bit about people who have persistent neurologic symptoms when they present to the emergency room. These are people that are not going to be TPA candidates because they presented outside of the acute thrombolytic window, which we'll talk about a little bit later. But for those people who have a fairly mild stroke syndrome, and we estimate that that's going to be about 50% of people would have a stroke scale less than 5, that we would be able to consolidate a traditional several-day hospital stay and move them towards an expedited pathway of observation status and a complete pathway of care within 23 hours by removing some of the non-value-added time latency that occurs in a traditional hospital stay, again addressing a disgustor of patients where they are simply waiting in their hospital room, waiting for care to be delivered, but not necessarily adding value to their hospitalization. We would provide the same standard bevy of diagnostic tests which are appropriate, standard pathway for stroke patients, and then get the appropriate secondary prevention bundle prior to their discharge home. We would also want to make sure that they have near-term follow-up and a support line with an advice nurse to ensure that they have the appropriate follow-up care. Next, we're going to talk a little bit about transforming patient care for acute thrombolysis. We learned a lot from different innovators across the world, and we were particularly inspired by Dr. Atte Meretoja from Finland, who we were fortunate enough to be able to give a little soundbite about how he was able to transform acute TPA delivery in Finland and then subsequently brought it to Australia. So hold on a second.
I'm unplugging to see if it's coming out of the laptop.
University Central Hospital, and I'm an associate professor of neurology at the University of Helsinki and at the University of Melbourne. Now, I've been asked to briefly summarize for you my personal experience of delivering TPA very fast in acute ischemic stroke. We recently reported the relevance of this speed, and one can actually summarize it with the phrase "save a minute, save a day." That basically means that every 15 minutes that you are able to cut from the initiation of the treatment, an average patient will gain 1 month of disability-free life, or an equivalent of that. Now, speed is crucial, and Helsinki is at the moment the fastest center of delivering TPA in acute stroke. The Helsinki model, which we reported a year ago, was developed over a period of about 15 years. We started after the ECAS-2 trial ended in 1998, and we've been developing our model since. Now, the crucial elements of the Helsinki model are that we need to get accurate pre-notification. that will allow us to prepare before the patient arrives. Now in Helsinki, what happens is that the ambulance crew will call me or one of my consultant colleagues, whoever's on call for the acute thrombolysis service. And when they call me, I'll ask them to pass that mobile phone over to the relatives, the eyewitnesses, or the patients, if the patient can talk. And then we'll discuss the acute event. So we'll actually know what happened when the stroke started, and the information will be passed on to me during transportation. Now, after the pre-notification and getting the acute history over the phone, I will access the patient's medical records, their previous imaging, and so on. So I'll have a full history available already before the patient arrives. I'll pre-require the CT. I'll ask for the laboratory nurse and the ED nurse to arrive with the TPA at the CT, and then I'll go and wait for the patient at the CT. So when the patient hits the hospital doors with the ambulance crew, they'll go directly into the CT room, bypassing the ED cubicle. And the patient will be lifted from the ambulance stretcher onto the CT table. I will rapidly do an NIA stroke scale evaluation, will image the patient and start the drip on the CT table. And that's basically how in Helsinki we are able to treat 50% of our patients faster than 20 minutes. At the moment it's actually 17 minutes and about 75% of the patients within 30 minutes and practically everyone within an hour. The crucial steps are to bypass the ED cubicle and to go directly into the CT. Now, we recently also applied the model in Melbourne, Australia, where I did a 1.5-year fellowship. And in just 4 months, using these basic principles from the Helsinki model, we were able to cut our door-to-needle times in hours when the new model was applied from 45 minutes to the present 21 minutes. And that was a really rapid process. It took only 4 months. So basically, the crucial thing is do as much as you can before the patient arrives and as little as possible after that. I published the Helsinki model and the experience in Melbourne in 2 papers in Neurology last year and this year. So please be welcome to check out any further details in those papers. Thank you very much for this opportunity to talk to you, and I hope you enjoy your conference. Goodbye.
So I think some of the things Dr. Meretoja highlighted, which are particularly exciting to A, we were very inspired from him and working on some of these process changes here at Stanford, and B, also the fact that he was able to quickly disseminate what is a fairly unique model in Finland, which is very integrated, to another place all the way around the world in Melbourne, Australia. And so I think for a group here which is really focused on translational to direct bedside care, the idea of being able to potentially disseminate some of this work to best practices in California is also very promising. So some of the things that Dr. Meretoja highlighted, which is primarily focusing on better pre-hospitalization care with as much clinical high touches as possible, potentially using telecommunications, which I think the Mercy Jim Roxburgh group here may be sharing later on this afternoon, as well as circumventing some of the non-value add work done in the emergency room and potentially bypassing them altogether and taking the patients directly to CT, where the rapid evaluation with imaging and subsequent TPA delivery can be offered in as shortest amount of time possible. And so potentially there's a lot of opportunities here where there are some areas that may not have the best access and care in California. I'm thinking maybe people that are less represented here in the Central Valley, that potentially growth to hub and spoke model, teleneurology models may also be beneficial in this place. Next I'll be turning it over to my colleague Jared.
before you sit down, she keeps forgetting to do this, so excuse me. But so if I think the current, you told me that the current mode, sort of mode for median value for door to needle time nationally, even though there's a lot of variation around it, is about 80 minutes. Helsinki, we're at, let's say, 17, let's round it up to 20. About how many neuron deaths prevented would occur per patient if we could take the 80 down to 20?
Based on some modeling work that Jeff Saber did in the 2009 paper, there's estimates that about 1.9 to 2 million neurons are lost a minute. So I think the goal here, which I think Dr. Meretoja also alluded to, would be potentially reduce 100 million neuron deaths per patient, as well as potentially, improving non-disabled quality of life days for each patient. So.
Fantastic. So some exciting work going on in Finland and Australia that we were able to adapt, and we are excited to see how that pilots here in some of the sites we're working with. So as an individual that has had a stroke, about the last thing you want to do over the course of the next 3 to 6 months is have to go back to the hospital. And unfortunately, this happens all too often. About 40% of patients at 1 year are readmitted to the hospital post-stroke. Now, this turns out to be not only, of course, a disgustor for patients, but also for providers who have done their very best to deliver very high-quality care while the patient is in the hospital, only to see their patient readmitted, due to a lot of system issues that hopefully can be addressed. And so with that, we aim to design a new process of care that hopefully addresses that and improves readmissions, the preventable ones at least, by 50% at 1 year. The first piece is a proactive identification, as you saw in prevention, a common theme of those who are at increased risk of readmission. Now, this doesn't necessarily just represent those at high risk. Some of the pioneers in this work, including those at UPMC, have shown that you can actually, there's a sweet spot often in those at more moderate, kind of the moderate to high risk area that might actually have more room to move the dial. And so we're including both of those groups, again, using some of these same data systems that are possible in the 21st century. The second piece is what we call kind of a high-value transitions checklist that is used by people already in the clinical team in the hospital. But essentially this is a more targeted and enhanced approach. So some of the key steps here, improved medication reconciliation, improved screening of depression, perhaps. We're also looking to identify some of the red flags, and essentially you're beginning the first phase of teaching these patients what to look for, what to help to prevent from occurring this event back in the hospital. Now a lot of this gets lost. The literature shows that these patients are at have a cognitive deficit and might not even take in all this information, and so we designed for that. And what you see is these same health coaches that have already established a relationship with patients, that they have the same opportunity in this post-hospital state to again engage with these patients and reinforce a lot of the teachings that happened in the hospital, identify some of the red flags, ensure that these patients are actually taking all this in despite some of the deficits that they might have incurred. And lastly, just got to get the hands back in the arms of the quarterback. The evidence is clear that in readmissions, as probably many of you know, getting the PCP involved quickly after hospitalization is key. And so we add that as a final piece within the 7 to 14 days. So in sum, this segment of the model will reduce the preventable readmissions, which are anywhere to 20 to 30% of all stroke patients down to by half within the first year. So taking the model all together, this is our last piece. You can see kind of what we've done. This is a busy slide, but what you'll see is on the y-axis, this represents those for a population of about 50,000 as a member group. And what you'll see, these are again average numbers for the US, because we work with systems all across the US. We can tailor these as needed to any group. But you see the y-axis is cost savings. The x-axis, it represents kind of the elements of the care model, the A, the C, and the T. And you see that there's a vast improvement in prevention for this 50,000 population. Again, about 20% of them are at high risk, so 10,000. You see 70 heart attack and strokes prevented. In the first year, about 110 hospitalizations avoided, or converted, to care in these lower cost settings. And finally, some drastic improvements in disabling stroke numbers, as well as readmissions. And finally, for an 11% improvement in the cost fuel burn that Arnie mentions, while, of course, really improving the quality in AAA. So with that, we thank you.
My job as the coach is to make sure they're taking credit for everything they did. I want you to just direct your attention to is the two right-hand bars. Because obviously, preventing bad stuff in ways that adds to Uncle Sam's burden is the last thing we need at this point. And so if you look at the difference between the dark bar and the light bar, that difference is what we believe is the cost of the intervention, which, as you can see, thanks to this design team, was a relatively small. The difference between gross and net savings is the incremental cost of the intervention. So it's but in year 3, yeah. And so they also, I'd say, succeeded on that dimension, which is come up with an intervention that does not have a lot of spending relative to the near-term downstream savings that it achieves. Steve?
Thanks, Arnie and the team. I think we ought to really create a new award, an additional award, Hattie, which would be the Clinical Design Award here for what we've just heard. But it's wonderful work, and Arnie and others, as he indicated, he's going to be working on surgery care, I think, this year, and there's other things they're working on as well. But a lot of this is trying to get this out in front of people like you, because you are the ones that can run with this and implement, throughout the state in your various settings.